Is true about degenerative myopia. More common in males as compared to females. Is it true or false? What do you think? Don't think so. No. Here we have no sex predisposition, so this is not true. Myopic degeneration can lead to retinal detachment. Is it true or false? Yes, sir. Yes, it's true. In degenerative myopia, you have degeneration in the periphery of the retina. Here, you will have tears, you will have holes, and after vitreous liquefaction, you will have retinal detachment. Myopic degeneration can lead to retinal detachment. Yes, this is the B. So, it is seen in myopia less than 6 diopters. Is it true? No. In most cases, it is more than 6 diopters. But don't forget, sometimes you can have myopia less than 6 diopters, and again, you can have problems with the retina. So every patient with myopia must be, the retina of every patient with myopia must be examined once per year. Retinal tear is less common and is a late complication. This is not true. We know that if we have myopic degeneration, we are going to have retinal tears because the retinal degeneration. Okay, what is Foster-Fuchs spots? They're specific for myopia, hypermetropia, sympathetic ophthalmia, or astigmatism. What do you think? Myopia. Myopia. This is something very, very specific for the myopia. And here is the picture of one Fuchs spot. It is in the macula. Here you have hemorrhage in the macula. You have degenerations in the macula. You can have new vessels. The process is called neovascularization. And here, young patients with high myopia have complaints of adults with age-related macular degeneration. This is the problem with degenerative myopia. You can have retinal detachment because of the degenerations and tearings and holes in the period of the retina. You can have problems with the macula because of this Fuchs spot. This is so-called myopic macular degeneration. And here, these patients are treated like the patients with wet age-related macular degenerations, intravitreal injections of anti-vaso-endothelial growing factors that will reduce these new blood vessels that can very, very easily bleed in the retina. And here you can see this is the head of the optic disc. In myopia, myopic patients have big and power heads of the optic disc. And here this is the myopic crescent. Here we have degeneration of the retina and choroidea here around the temporal border of the head of the optic disc. And here you can see the sclera. This white here is the sclera, and this is the temporal myopic crescent that is specific for myopia. Again, it's not necessary the myopia to be more than 6 diopters. You can have a patient with 3 diopters myopia who will have this myopic crescent around the temporal border of the retina. Okay. Pseudopapillitis is seen in hyperopia, myopia, squint, or presbyopia.
Hypermetropia.
Yes, hypermetropia. Here in hypermetropia, especially in cases when you have high hyperopia. What means high hyperopia? Hyperopia more than 5 diopters. When you have hyperopia small. Here, the head of the optic disc is small, and very red is hyperemic. The borders, the margins of the optic disc are blurred. The blood vessels are dilated and with some types of tortuosity. Therefore, in these cases, you can think about inflammation of the head of the optic disc. But this is not true inflammation, therefore we are talking about pseudopapulitis. Okay. True about presbyopia. This is a problem with the accommodation. So here we have age-related defect in accommodation. The problem is with the lens, the elasticity of the lens capsule, and with the cortex of the lens. The lens can't change its length and can't increase its refractive power. Therefore, we have presbyopia. When you have a patient that is 45 years of age and has his first presbyopic complaints and he is with Ametropia, what type of glass lenses you're going to prescribe this patient? Plus 1.5. Presbyopia in most cases starts at about 45 years of age in ametropic patients or patients with very small hyperopia. In these cases, you're prescribing your patient convex lenses of 1.5 diopters. After 5 years, the rule is that at 50 years, you're going to give this patient 2 plus 2 diopters. At 55 plus 2.5, and at 60 plus 3 diopters. Because at 60 you don't have any accommodation, and if your patient wants to read, and the normal reading distance is about 33-35 diopters, you must increase the refractive power of the eye with 3 diopters, and here you will prescribe plus 3 diopters. If your patient is not with ametropia but has hyperopia, that must be corrected even for distant vision, you will give him more at 45 years of age, you will give this plus 1.5 plus his correction for distance. For example, your patient is with hyperopia. He wears glasses for distant vision from plus 1 diopter. If you want to read at 45 years of age, you must give him plus 2.5 diopters. And if your patient is with myopia from minus 1 diopter and you want to prescribe him glasses for reading at 45 years of age, you're going to give him just 0 plus 0.5 diopters. Okay, if you have a patient with minus 2 myopia, and this patient is at 45 years of age, how big will be his presbyopic correction? What do you think? Minus 2 for distant vision. He wants to read and he is 45 years of age. Are you here?
Yes, we are here.
Okay, because nobody is talking and I think that I'm alone. Your patient is with myopia, minus 2 myopic refraction for distant vision. He is 45, he has problems with the reading. What type of refraction for close visual working, you're going to prescribe him. Plus 1.
Plus 1.
Plus 1 y plus 1. He's with minus 2. Minus 2 for distant. And you're adding plus 1.50 for near visual work. And the sum is
73.5.
minus 0.5. Okay, okay. And your patient...
Professor, can you explain again the mechanism of thinking?
Okay, when you have ametropic patient, he's 45 years of age. Ametropic patient means that he doesn't need any glasses for distant work. But he's now 45. He has problems with near visual function. You must prescribe him glasses, and you will prescribe him plus 1.5. This is the rule. You must know this rule. 45 ametropic plus 1.5. Ametropic with ametropic patient 50 years old plus 2. Ametropic patient 45 years plus 2.5 diopters lenses for reading, and 60 ametropic 60 years of age or more plus 3 diopters. This is the case when you have ametropia, when the glasses for distance are 0. You don't have glasses for distance, so the glasses are 0. When you have hyperopic patient and he has his distance correction, you will use this distance correction and you will add plus 1.5 at 45 years of age, plus 2 at 45, plus at 40, plus 2.5 at 55, and plus 3 at 60. And, for example, the patient is with hyperopia plus 0.5. He uses these glasses for distant work. For near, he is 45. For near, you will give him plus 2. 0.5 for his distant vision. You're adding plus 1.5 for his 45 years of age, and the final lenses are plus are 2, plus 2. If the same patient is 40 years of age, he has plus 0.5 for distant, but here the glasses will be 2.5. When you have myopic patient, he's wearing glasses minus 1 for distant. Now he's 45. You must prescribe him glasses for reading. Minus 1 for distant. You're adding plus 1.5 for reading for the ametropic patient at 45 years of age. And the final prescription for this myopic patient with minus 1 diopters for distant vision.
0.5.
Yes, is 0.5. And okay, you have the same patient. He's with myopia, minus 1 myopia, and he's 60 years of age. What you are going to prescribe him? Plus 2. Plus 2. Okay, you have a patient with minus 3 diopters for distant vision, and he is 60 years of age. What are you going to prescribe him for reading?
Nothing.
Nothing. Yes. you're going to tell your patient just to take off his glasses. Maybe you have relatives that are with presbyopia and are with myopia. When they want to see something that is closer, they just take off their glasses and they can read without problems. Therefore, when I have students and they're with myopia at about 3 or 2.5 or 2 diopters, and they're asking me about the laser correction of the myopia, I am telling them that this is not good for them. Why? They will be dentists or they will be doctors. In most cases, they will have near work all the time. And when they become presbyopic, it's going to be more easy for them to take off their glasses and to work something that is near than to use again glasses, but in these cases for near work. And if you have myopia or if you have some form of refractive errors, you're wearing glasses and you want to take off your glasses and to make laser correction of the refractive error, just think why you want to do this, and don't forget that everyone will have his glasses. Some have their glasses from children, and other takes their glasses after 45 years of age when the presbyopia starts. And think, what is easier, to take off your glasses for reading or to use other glasses, one glasses for distant vision and other glasses for reading? Okay, what is Aniseikonia? What do you think?
Two different sized images being produced on the retina?
Yes, difference in the size of the images formed by the two eyes. And this is the case when you have very big Anisometropia. This is difference between the refraction of the two eyes more than 1 diopter. In these cases, in the two eyes, on the two retinas, you're going to have images with different size. And sometimes it's very difficult for the brain to mix these two images and to have one three-dimensional image. Okay, when we are talking for Anisometropia, the most awful thing is with Hyperopia. When you have Hyperopia, just Anisometropia more than 1 diopter can give you Amblyopia, or so-called lazy eye. When you have myopia and you have Anisometropia, here the difference between the two eyes must be more than 3 or even more than 4 diopters to have a risk for amblyopia. But for Hyperopia, even 1 diopter difference between the refractive power of the eyes is a risk factor for lazy eye. And in these cases, you must treat the child. You're prescribing him the glasses and you're covering the good eye with the occlusive patch. This is the way we treat lazy eye, amblyopic eye. Patching of the good eye in different regimes of occlusion, and we're warning the bad eye to see.
Professor, what is the therapeutic result we expect from this lazy eye treatment for the, to achieve 100% vision?
Oh no, yes, but it depends when when the amblyopia is diagnosed. If you have a small patient that is less than 6 years of age, you can expect very, very good response to this amblyopic treatment. If the patient is older, more than 6 or 7 years of age, it's very, very hard to try to do something with the amblyopia. We have so-called sensitive period. This is the period from birth to 6, 7 years of age. This is this period when we can have treatment of amblyopia, and different amblyopic factors can produce amblyopia. The best age of diagnosing and starting treatment of amblyopia is before 4 years of age. After that, between 4 and 6 years of age, you can have good, not the best, but good results. But after 7, 8 years of age, the result is not very good because you're outside this so-called sensitive period. If you have a patient that is more than 10 years of age, you're not going to have any results from the treatment. The amblyopia must be, or the amblyopic factors must be diagnosed early. So, early diagnosis, early treatment can be started. And if it's very early, is the start, the beginning of the treatment, you will have really good results with 100% visual acuity. But here is the role of the screening examinations. Again, we're talking about screening. Here, when you have amblyopia, in most cases, the patient has no complaints. The child will have one good eye with 100% visual acuity and one bad eye. When the patient is looking with his both eyes, the visual acuity will be normal. And sometimes when the patient incidentally closes his good eye, he understands that there are problems with the amblyoptic eye. And don't forget that the child can't explain us what is the problem. Sometimes the children think that it's normal one of the eyes to be with good visual acuity, the other eye to be with bad visual acuity. Here, screening again is the most important thing. At 6 months after birth, about 1.5, after that between 3.5 and 4 years of age, and after that before starting school. Here in Bulgaria, the children start school at 7 years of age. But if you want to diagnose and treat properly amblyopia, you must diagnose your patient before 3.5 or 4 years of age. Okay. Let's see the next. Treatment options for myopia. I don't know is the lecture. Do you have any information for the different operative treatments of myopia? About refractive surgery?
It wasn't mentioned in the lecture that.
Okay, yes. So, here, when we are talking about refractive surgery, in most cases, we mean this, LASIK. This is the most modern LASIK or LASIK, the most modern types of refractive surgery. Radiokeratotomy is the first type of refractive surgery, and now nobody uses this type of refractive surgery because here in radiokeratotomy presbyopia, you're making many radial incisions of the cornea, and the aim is to make the cornea flat. Now we are using laser. Okay, so contact lenses is one very comfortable way to correct the refractive errors. It can be used for myopia correction, for hyperopia correction, and even for astigmatic correction. In astigmatic correction, in astigmatism, we are using so-called toric contact lenses. Here, you have the lens has refractive power just in one of the meridians, and the other is with ametropic refraction. Okay. Tropicomet, this is some type of sympathicolytic and parasympathicolytic, and we use it mainly, but we use it mainly for dilation of the iris, because the effect on the accommodation is not very strong. When we want to block the accommodation, to relax the accommodation, when we want to examine the real refraction of the patient, so-called static refraction, you know that we are using different type of drops that are blocking the parasympathetic function of the ciliary muscle. In most cases, we are using atropine or cipopentolate. When you use atropine, you use it for 3 days, 2 times per day, and after that your patient will be with insufficiency of the accommodation about 10 or 40 days. When we use so-called fast cipoplegic drops, we are using cipopentolate. Just for 1 hour, we can have insufficiency of the hypoplegia, and the effect of this cipopentolate is about 12 or 24 hours. Here in this question, which of the following is not hypoplegic? The right answer is phenylephrine. This is sympathetic drops, and here the only effect of these drops are on the dilator of the iris. You have dilation of the pupil. The others, atropine, home atropine, and tropicomet, they are parasympatheticolytic drops. They block all parasympathetic nerves. These that innervate the ciliary muscle, and these that innervate the sphincter of the pupil of the iris. Therefore, again, here you can have mydriasis. The pupil is dilated, but not because the dilator of the muscle dilator of the pupil is innervated, but because the parasympathetic nerves that innervate the muscle sphincter of the iris is blocked. Okay, here the next question: mydriatic to be used in a 3-year-old child for refraction.
It's going to be A.
A, yes, atropine drops, not ointment, because you're going to have very, very long effect on the accommodation and on the mydriasis, on the diameter of the pupil. Okay, objective assessment of refraction is termed B, yes, retinoscopy. This is the one objective assessment of refraction, and we use it every time when we have very small children that can't be examined on the autorefractometer. Gonioscopy is a method for examination of the anterior chamber angel, and ophthalmoscopy is a method for examination of the retina. It can be direct ophthalmoscopy and indirect ophthalmoscopy. The difference is what type of instrument you're using. And keratoscopy is a method for examination of the cornea to see the refractive power of the cornea in the different meridians of this of the cornea. So here you can examine the cornea when you have astigmatism, or in cases when you have keratoconus. This is a pathology of the cornea when the refractive power in the different parts of the cornea are different. Not in the different meridians, but in the different parts of the cornea are different, and in some parts the cornea is very flat, in other you can have problems of tearings of the cornea. So this is keratoscopy. In retinoscopy, for a distance of 1 meter, the correction factor is -1 diopter. What is the correction factor for the retinoscopy done at 66 centimeters? Here, the idea is to find where is the punctum remotum of one eye. When you have when the punctum remotum of one eye is 1 meters, this means that this eye is with -1 myopia. When punctum remotum or distant point of clear vision is at 66 centimeters, this means that this patient is with about 1.5 diopters myopia. So here in these cases, in retinoscopy, the correction factor will be -1.5 diopters. Okay. On performing retinoscopy using a plane mirror in a patient who has a refractive error of -3 diopters, that's here, with -2 cylinder at 19 degrees from a distance of 1 meter, the reflex would move. What do you think? Okay, here is see against the movement in both the axes. Okay, here 25. A 35-year-old man has 6/5 vision in each eye. His hypoplegic refraction is 0, so he is with Ametropia. He complains of blurring of newsprint at 30 centimeters, which clears up in about 2 minutes. The probable diagnosis is C. Accommodative insufficiency. Or hypermetropia.
Yes, C, I think.
C, okay. It's not presbyopia. He is ametropic. Ametropia starts at 45 years of age when you have ametropia. If you have very high hyperopia, the presbyopia may start even earlier than 45. But in ametropic patients to talk about presbyopia, it's impossible. Okay, and here are the last questions. A 35-year-old man has normal distance vision, but complains of difficulty in near vision. His retinoscopy shows +2 diopter sphere. The probable diagnosis is
A.
A hyperopia. Yes, here we are talking about hyperopia. This patient is with +2 diopters. In the beginning at 35, here the first complaint will be with close vision, near vision, and after that he is going to have problems and with distant vision. But again, here is hyperopia, not presbyopia. A 10-year-old boy is brought to the doctor with complaints of squeezing his eyes to see the blackboard in school. What is the probable diagnosis? It's very easy here. Myopia, yes. The first complaint in most patients with myopia. And a 9-year-old boy is brought with complaints of difficulty in vision for distance. On examination, the visual acuity on Snellen's chart is 636, but it improves to 6 with pinhole. What is the diagnosis? Refractive error. The pinhole, this is
Astigmatism.
Yeah, the refractive error, we are not sure. It can be astigmatism, it can be a myopia, it can be hyperopia. Here the idea is that your patient will have 100% visual acuity with this pinhole. This is one black obturator with a pinhole in the center. And when the problem with the low visual acuity is just a refractive error, when you put this pinhole in front of the eye and again starts to examine the visual acuity, the visual acuity of the patient will be higher and even normal. If you have some organic pathology, the visual acuity will decrease with this pinhole. So you can use the pinhole for examination, the reason for the low visual acuity. And treatment of choice for aphakia. What is aphakia?
That's lack of a lens, right?
Yes, lack of a lens. In most cases, it's after operation for a cataract, or it can be after trauma when you have luxation of the lens in the vitreous body or in the anterior chamber. You have aphakia. Here you are going to have very high hyperopia at about 50 or more diopters. And the best treatment possibility for aphakia is intraocular lens. Yes, intraocular lens implantation. You can use contact lens. Yes, contact lenses are very useful when you have big difference between the diopters of the both eyes. And spectacles, you can use spectacles if you have aphakia of the both eyes. If you have just monocular aphakia and if you try to treat it with spectacles, you're going to have very, very big, awful Aniseikonia, and your patient will be with a headache all the time. But intraocular lens implantation is the most normal, artificial way for treating aphakia.
Professor,
Okay.
can I ask how long does an intraocular lens last? Is it life?
Yes, it's for the whole life. Yes, when you implant it, it's for the whole life. Therefore, it's very important to measure the refractive power of the intraocular lens that will be implanted very carefully, because it's for the whole life. Sometimes, if there are very, very big mistakes with the calculation of the intraocular lens power, some surgeons, cataract surgeons, but not many cataract surgeons, can try to extract this artificial intraocular lens and to change it with another. most cases is just one implantation for the whole life.
Okay, thank you.
Okay. I think that's all for today. Have a nice day. Have a nice holiday.
Professor,
Mhm.
can I ask you, before we go, we talked about how moderate and degenerative myopia can lead to macular degeneration.
Yes.
How is this pathophysiologically connected? Like the refractive error of myopia with the pathology
Here.
of
You have high myopia. The eye is very long. The retina is very thin because the eye is long and the retina is stretched and is very thin. Here you will have problems with the normal oxygen feeding, blood feeding of the retina, and especially the most important part, the macula, because you're going to have here hypoxia of the retina, some type of try of the eye to improve this hypoxia is developing of new vessels around and under the macula. But these new vessels are not normal vessels. They bleed very, very easy. You have hemorrhages. After hemorrhages, you will have fibrous tissue in the hemorrhages, and this is the way for this macular degeneration. Therefore, the treatment is with these intravitreal injections of anti-vasoendothelial growing factors that will reduce the process of neovascularization. The third thing is very long eye, very stretched and thin retina, after that hypoxia and new vessels formation.
Thank you very much.
Okay. And again, not in every patient with high myopia and degenerative myopia, you will have myopic degeneration of the macular or retinal detachment. But these patients are with very, very high risk, and they must be screened one per year. Okay? Have a nice holidays. Bye-bye.
Can I ask you also one more question? Sorry.
Yes. Sorry.
It's related to the anatomy.
Okay.
What exactly is the hyaloid canal in the vitreous body?
Okay. Here, during the pregnancy, when you have the formation of the embryo and fetus, and when you have formation of the eye, the vitreous body is not a transparent structure. The vitreous body has its own blood vessels, the main blood vessels of which is hyoid artery. After the normal process of development of the baby and the eye, this hyoid artery and all the branches of this hyoid artery obstruct, and the vitreous body becomes transparent. And in the normal vitreous body, without any problems, without any pathology, when it's transparent, you don't have this hyoid artery or its branches, but it can be seen as a channel in the vitreous body, and this is so-called flocket channel, or channel of the flocket. This is the place where the hyoid artery of the embryo was in the vitreous body.
Thank you very much.
Okay, other questions?
Professor, if we have a patient with low degree astigmatism, let's say from 1.5 to 2 diopters. But his work requires a competent and very clear sight. Let's say he's a surgeon or a neurosurgeon. What would be the suitable treatment for him, if there is any?
If you have a patient with small astigmatism at about 1.5 diopters.
Yes.
Okay. 1.5 diopters astigmatism is not so low astigmatism. You know, one term, it's physiological astigmatism. This astigmatism is at about 0.5 or 0.75 diopters. If you have astigmatism more than this 0.75 diopters, your patient will have complaints. Not just for distant working, but for near working. And in most cases, we are prescribing glasses. If with both eyes, this patient has 100 or 90% visual acuity with both eyes for distant work, you can prescribe these glasses just for reading. But it's good for this patient to be with these glasses for near work, because not just the problem with the vision. This patient will have problems with headaches, with chronic conjunctivitis, with chronic inflammation of the eyelid, and really awful headache, especially in the evening after a hard working day. So prescribing glasses here.
Thank you very much.
Okay, another questions?